All right, we are live. Meeting is now streaming live on YouTube. Great. The amount of technical things you have to do for this, you guys have to appreciate, getting 6 people on a Zoom call. It's just a lot of fun. It's a lot of fun getting everybody in. In fact, one of our participants just emailed me also having trouble getting in. I will try to address that real quick, and then we will get on to the show. People are. All right. All right, I'm going to start with the, I hope everyone can join here shortly. Fantastic. Welcome to This Week in Health IT Live. My name is Bill Russell, Healthcare CIO coach and creator of This Week in Health IT, a set of podcast videos and collaboration events dedicated to developing the next generation of health leaders. We actually have 2 sponsors for today's show, Series Healthcare, who has been gracious enough to sponsor every episode since we started the COVID series, which has enabled us to really produce these daily shows. And VMware was our first channel sponsor for the show, and they have stepped up to help us to expand our offerings to live shows. I greatly appreciate these pioneers who support the show's mission to develop the next generation of health IT leaders. Special thanks to VMware Series Healthcare for making this show possible. Okay, are you ready for this? We'll see if we can get everyone on the line, but I'm going to get us started here. I'm really excited for this show. Let me set the stage for how I think this is going to go. I'm going to ask everyone to provide opening remarks based on a question that I sent them ahead of time. This will take roughly about 10 to 15 minutes to set the stage. And at that point, we're going to start answering your questions from the chat that is going on right now. We have a few questions that were sent ahead of time. We anticipate questions from the chat as well, so we'll bring all those together. My staff is monitoring the chat, so you can start sending those immediately. Let me introduce everyone, and then we'll get to the questions. We have a great panel of participants for today's shows. We have a view from DC, and we have a view from the chair. That is the CIO's chair. We have Mari Savickas and Andrew Tomlinson are here from Chime as our representatives in the Capitol on all things health IT. And we have 3 clinicians on the ground, Stephanie Lahr, CIO, CMIO of Monument Health, Praveen Chopra, CIO for George Washington University and Hospital, and Albert Oriol, the CIO for Rady Children's in San Diego. Good morning, everyone, and welcome to the show.
Morning.
I am going to, this will probably be the last time we have this Brady Bunch shot, and then I will change it over to whoever's speaking. We'll have the whole screen, and we'll go from there. All right, here's where we'll start with. Let's get started with the providers. We're just going to go around the horn. I'd like to hear, where telehealth has made the most impact for you, the kind of growth that you've experienced since March 1st, and what kind of feedback you've been getting from clinicians and/or patients in the community. And Albert, if you want to kick us off, we'll go from there.
Sure, happy to do so. Good morning, everyone. So I'm the CIO at Rady Children's in San Diego, and I would say the growth that we've seen has been spectacular. We were literally doing somewhere around about 5 to 10 visits a day on telemedicine across our various service lines, whether it was the medical specialties, our developmental services, or primary care, before this whole thing started. And now we are doing somewhere between 700 and 800 visits a day. So the growth has been phenomenal. For a while in the early stages of the pandemic crisis, our percentages got pretty high. Our volume overall tanked, but our percentages were somewhere in the 70% of those visits were telemedicine. Now that that volume is beginning to flow back in, we're not at 100% of our normal yet, but we are seeing those percentages shift, and it really varies by specialty. We're on average doing somewhere between 40 and 50%, and obviously in the medical specialties that is higher, and the surgical specialties that is lower, and we're somewhere in that area, around 40 something percent. So pretty dramatic change. It's been quite interesting to see how some of the clinicians who a few months ago assured that telemedicine was not something on their horizon, or would not work for their specialty, have really changed their perspective on telemedicine once they've had no option but to do it that way. And we know change is hard, and I'm just so proud of folks keeping an open mind, being willing to try new things, to make things work. And some of them will stick. Some of them, have been able to get through the patch to see patients that needed seeing at a time when people were asked to stay at home, and we'll get those patients back in the office now that things are getting a little bit more stable. So a lot of change. Just amazed at the incredible resilience of our clinical providers. Our patients have been great. The feedback that we've gotten overall has been fantastic. And I suspect, like many of my peers, we will see a before and after this crisis when it relates to telemedicine. I think that I'm going to pause here and let the next person go. I think I've probably exhausted the time you gave me.
Fantastic. So Stephanie, we'll let you go next. And it's really impact, growth, and feedback that you're hearing.
Sure. Thanks. Good morning, everyone. So maybe just for a little bit of perspective, I am at Monument Health, which is in Rapid City, South Dakota. So we serve most of Western South Dakota and some of Eastern Wyoming and a little bit of Nebraska. We are obviously rural, and interestingly, you might think that telemedicine for us, because of our rural nature and limitations that we have in access to providers, might have been a large part of what we were already doing. It absolutely was not. I don't have to do any rough calculations to say we started in late March with 0 telemedicine visits that we were doing on an average daily basis. That average of 0 was pretty easy to calculate. And then we moved rapidly from 0 to about 600 visits a day across the health system. That ramped up quickly, and our patients, their families, the providers all took to it actually very excitedly. We did a rollout unlike we would normally have done with any other technology. It was very hands off, do it yourself. It's not the perfect technology, but just make it work. And people did. We have now the benefit of having, for example, some of our Press Ganey patient satisfaction scores back, which are demonstrating that our patients are at least as happy, if not more satisfied with their visits when they're done via telemedicine. So that's fantastic to sort of, especially with something that really didn't have a lot of structure behind it. We didn't give really any guidance on what kinds of patients, what kinds of visits. It was do all of this way right now. For neurology in particular, they were a specialty that, for example, was scheduling patients out 3 and 4 months prior to telemedicine. And we had a telemedicine strategy that we were preparing to sort of roll out. It completely got thrown on its head as we had to morph into something different. And actually, most of the things that were on that plan are very different now, in large part because of the limitations that we had previously related to payment, licensure, a number of those things, especially being in a border state, that we now don't have as obstacles, at least temporarily. So for neurology, they've actually been able to decrease their time to that first appointment because they're also using space differently. So a provider is sitting in an office that doesn't need an exam room and is able to see multiple patients in a block of time, while their partners are out in the clinic space seeing patients that need to come in for in-person visits. So it actually has increased their capacity to be able to do more with less space. And we're now evaluating sort of long-term, how does this need to play into our space strategy? Another interesting example, being rural as we are, if we have specialists that are sort of taken out of commission by COVID-19, there is no backup option. There is no other health system or center to send those patients to. And so, for example, in our cancer center, we developed a program that I called our physician conservation model. And so we had half of our radiation oncologists and half of our medical oncologists working from home, and the other staff working in the hospital or in the clinic, so that if we had an exposure in one of those clinical spaces, we had backup staff who we knew hadn't been exposed, who could swap out while we were waiting for testing and other kinds of things to come back. So those two examples are, I think really demonstrating for us the success and adoption and unique ways that we can think about using telemedicine. The final one, for us, our numbers are really just starting to go up now. We followed, sort of the rest of the country from the standpoint of what we were doing with social distancing and modifications. We rolled out telemedicine right away, but numerically, based on the prevalence rates of COVID-19, we're really more in a situation, moving into a situation now where these tools are going to be needed to help protect people. And so we are excited that we had an opportunity to sort of trial them in a lower stakes environment and now working through, but we also are integrating it into now a home monitoring program, leveraging both phone calls and video visits with patients, again, trying to keep those patients home and not having to come into our inpatient system, as well as helping to reduce the length of stay in the hospital by giving them a soft landing with a patient monitoring system once they go home, where we check in with them every day electronically and using tools. So, it's really showing us what we can do in a crisis and how we can use creativity and ingenuity and the tools that we really already had to make something work. And now it's going to be interesting to figure out what are those pieces that we want to hold on to, what are the pieces that are going to need some improvement, and how do we carry forward?
Yeah, that's fantastic. That's a great setup. Praveen, you have gotten into the call via audio. The question we were asking is, what has been the impact of telehealth at your health system? What has been the growth? And then what has been the feedback that you received from clinicians and or the patients?
Thank you for the opportunity. And I was listening to you, Stephanie and Bear. So you addressed multiple points. I think yes to all. And I would try and summarize it in like three things. I always say, crisis happened to us, all of us. So what is the bright side of looking at the crisis? So to me, I think the first one was the confluence of three Ps. We always knew that technology is not a barrier to, we are calling more like a virtual care, expanding telehealth to more about virtual care. So technology was not the barrier. There were other three Ps that needed to come together. The first P was the providers. The second P was policy. And the third P was patient. So I think this moment gave us brought the confluence of the patients, the providers, and the policy changes, which is a big one. So with that, I think people were ready. And I would say that the day when we went into like shelter and home, our volumes, our business went down by 2/3 the next day, even more than that. I would say probably we were down to 20% of our business. And we quickly ramped up. And I think the platform was there, and for us to exploit it needed to be explored. So within probably 2 weeks period, we were able to go back to 50% of our volume. And that 50% of volume, I would say almost 50% of that volume was enabled through virtual care. That was actually phenomenal. That was the second thing. So we had the right ingredients came together from the change management perspective. Number two, we were able to recover and clearly show the value proposition of what's happening. And third thing, I think, became really like we expanded the limit. I think we expanded the capability of virtual care to support 2 more programs. Remote monitoring. I think what happened was we know that we have to use their home as also a setting to monitor the patient either after COVID or before COVID. And we did that. I think that actually are showing some promising results. And number 2 is that we also expanded, we created a drive-through testing. And how do you actually have a workflow interface of telehealth to help patient go through a lot of screening process when they show up, so that they're not spending too much time during the actual testing while they're driving to our testing spots. Those are the 3 things that came together. I would say it was overwhelming, and now we are also changing our working with Press Ganey to add a component to the survey about hearing from our patient score, a concrete score about how do they say their telehealth experience was. But we have testimonials, I think, both from patients and from providers. They loved it. And I think one of the biggest change happened for us is I think we knew that our primary care base and more like cognitive subspecialty, they will actually pick up faster. We were surprised to see pickup in kind of a OBGYN, orthopedic surgery, and other surgical practices, urology, where people wanted to say, you know what, before I do the procedure, I'm now comfortable talking to the patients before they come in and also follow up with them after the procedure is done. So that to me was a really interesting pivot for us to see that some of our procedure-based providers were actually open for the first time to try this new platform. And the other thing we saw that psychiatry, 100% of the psychiatry went virtual, and I don't think it's going to go back. And lastly, I will finish by saying that I think we are now in the phase 2 of reopening, and I believe that the hybrid model is the way. I think that one of the critical success factors for that is to make sure that policy changes stay, and we continue to advocate retention of the policies that have been brought forth. And we are seeing now, I think we're beginning to see that on a 35% as we're ramping up the volume, 35% of the volume is still telehealth, and I don't think it's going to go down. So we're trying to figure it out, what is the future of healthcare for us in terms of the business model and the payment model. So with that, I will just pause.
Yeah, no, I appreciate that intro and a lot of information there. Mari and Andrew, I'm going to, Mari, we'll start with you. The reason telehealth didn't take off prior to this was funding. And then the second reason it didn't take off was culture. Well, we seem to have plowed through this culture because we, quite frankly, we just had the world's largest telehealth experiment that we could possibly have. So a lot of patients and a lot of clinicians have been introduced to telehealth, and the response has been relatively good. Now it just comes back to the funding. And with so much positive feedback, what needs to happen at this point in DC in order for them to see the value, understand the value, and to appropriate the right funds in the right areas to fund telehealth's future?
Well, first off, Bill, thanks so much for having us and for having our members, because I have a saying that in Washington, hearts and minds are one story at a time. And so it's really important to get the messaging out regarding this and the success stories. So I thought I would start with a little bit of level setting in terms of, how we actually got here and what we can expect for the future. So a lot of folks have used this analogy. I don't really necessarily, like the analogy that much, but you can't put the toothpaste back in the tube, but unfortunately you can. And I am an optimist. So I think that there is a lot of room ahead for us to make some impactful changes in Washington regarding this, but it's not going to be a fait accompli. So the first thing I'll say is I'll give credit to the lawmakers for acting swiftly. They definitely acted quickly. Now, was it perfect? Nothing's ever perfect. So it began on March 6th with the first installment of funding, which happened in the first stimulus package. And then in the third package, known as the CARES Act, there was a lot of flexibilities were actually codified temporarily. So again, just for under the pandemic. And there was also some money for the FCC, which I'll let Andrew get into in a moment. But what I wanted to share with folks is that the reason this is possible is for two reasons. There's the Stafford Act, the national emergency was declared, so that has to happen. And then also HHS announced a public health emergency. So two conditions have to be met in order for these waivers to move forward. And so essentially that is what has happened. So the waiver, the public health emergency waiver, is up for renewal every 90 days. It was last renewed on April 26th. It is up for renewal again on July 25th. So if I had a message for anyone who's listening who wants to see these flexibilities continued, is reach out to your lawmakers, because at the end of the day, this is going to be a very much a congressional play. There are some maybe limited tweaks that we could potentially see from the administration, but right now I think that's what we're looking at. And there have been dozens of bills that have been introduced, and we could talk about a little bit about some of those. But maybe before I get too far into that, I'm going to hand it off to Andrew to talk about some great interest from the Federal Communications Commission.
Yeah, I think one of the big pieces that Marius touched on is it's not just about being able to have access to the telemedicine services themselves, whether that's the software side services or patients being able to access it through their providers, but it's being able to make sure that people even have the broadband and internet access necessary to be able to utilize these services to their full extent. Some of the regulations and the policies within the Centers for Medicaid and Medicare Services and HHS rely on the use of both audio and video technology to be able to deliver these telemedicine services. Not everybody has broadband to be able to do that. Not everybody, when you start talking about the access to the internet, it's not even just the ability to have a two-way video communication. You're talking about people that can't stream a YouTube video. So the Federal Communications Commission, as part of the CARES Act, received funding through the COVID-19 telehealth program to help providers stand up their telehealth services on the inside, but they also have a connected care pilot program, which is going to be continuing on. And at some point in the summer will be fully opened up, which is going to help to give people access to high-speed internet within their provider communities. And that's a huge piece of this conversation that needs to continue as well, that it's about having good internet access as well as having access to being able to bill and reimburse, and the provider side requirements to make sure that telemedicine is something that can continue into the future.
Wow. Yeah. So this is not a simple. This is not a slam dunk, and it's not simple. I think some people are looking at it saying, "Hey, there's so much value here. Every health system is talking about the value. Clearly, the federal government's going to see this and move it forward. But it's very complex. To sort of narrow it down, I'd like to hear from the providers. One of the questions we heard earlier was, which modalities will benefit the most from continued funding of telehealth moving forward? I don't know. I'm just going to throw that out there. Any of the three CIOs want to talk about which areas would benefit the most if the funding continued at its current levels?
I can jump in. I think for us, a huge issue is direct to consumer, right? I mean, our whole plan before this was based on a model where we still had to bring the patients to some location, a physical location we own, because really direct to consumer was not something that we really had an option to be able to use or leverage on any broad scale. The other piece I think is, and some of this is more on a state level, is related to licensure and some of the programs and how, a lot of states have waived some of the requirements that they normally have. But again, being a border state for us, we have patients who travel all the time into our state and receive care. That's completely fine. But a lot of questions are arising if they're going to stay in their home. Can we or can we not deliver care to them, and what relationship do we need to have with them? How many hoops do we need to jump through in order to be able to continue a patient relationship that we've always had? It's just changing. So I think those are two primary ones of great concern to us that are, we're able to do what we're doing right now because those have been lifted. Another big financial one for us, because of our rural health nature, we do still have a large degree of dependence on the 340B program. And the 340B pharmacy related program has a lot of stipulations in it regarding how those medications and where those medications are prescribed in the process. Currently, it is acceptable for a specialist to prescribe one of those medications through a telemedicine visit and still receive the 340B pricing. That is something that if it were to go away, will limit how and where we're able to use telemedicine, because in my neurology example, they're bringing patients in sooner and they're doing great works, but if they need to use a biologic that would be prescribed and in a part of a 340B program, we won't be able to do that anymore. So those are probably three for me.
This is Praveen. Just to build on what Stephanie said, we believe, is about, in terms of potential and likelihood, I think direct to consumer, and I think more about with established patients. So being in DC, and as we're talking to more and more folks here, I think about the payment parity and likelihood that it will go beyond Medicare, Medicaid, and other providers will work on, is to make sure that we are improving or reducing the administrative burden related to existing patients. They're not very receptive to new patient yet, but say for the existing patient, direct to consumer, I said anything that you can do to engage with them to reduce hospitalization is a great idea, and we are receptive to that. And anything that you can do with the patient after they had a procedure in the hospital to make sure that they recover at home, I think there is a lot of receptivity to that. To me, I think that has a good potential. The other area that we would like to advocate for, being a multi-specialty practice, as all of us are, to support P2P, where physician-to-physician consults. So how can we enable that by providing the right kind of reimbursement? Because right now the biggest challenge is the reimbursement to enable that P2P virtual consult. And the third thing, which I think we have pockets and receptivity, is around remote monitoring. And to me, I think just like Stephanie, our biggest thing is we are watered down. So it's DC, Maryland, and Virginia. Licensure issue is a big deal. And not only the licensure, but I think the place of service is also a big issue. So we're trying to figure it out how the licensure and place of service is going to enable or hinder the progress of virtual care for us.
Yeah, again, fantastic. So, as we start to look at this, are there proposals? Talk a little bit about the proposals that are currently out there. Are there any proposals, and what are the proposals you're hearing in DC around continuing the funding?
So I would say that right now, in terms of looking at what would essentially be the fifth stimulus package, there isn't any indication that telehealth will be included in that particular package. But things change quickly, so I don't want to give people don't want you to lose hope just yet. But there are several standalone bills, right?
So let me ask you this question then, which is, what do our lawmakers need to hear from us or need to understand before they get excited and start supporting the funding of telehealth?
Well, there is, let me back up. There is widespread bipartisan support around this, but when it comes to brass tacks, there's going to be a financial element here. Absolutely no doubt about that. We have not seen a Congressional Budget Office score yet. So you have to like basically assess, the lawmakers have to assess what the impact is, say, to like the Medicare program. So if it's going to cost more, that becomes an issue, and there have to be funding that's identified. So I think what we're looking for is, when you're looking at your data, and this is really to those who are providers, is we want to find out, where the cost savings are, where the quality improvements are, where the patient satisfaction is. So that's more of a qualitative issue. Praveen just mentioned reduced hospitalizations. So there's a lot, I'm only touching on a few things that actually go into this. And measuring quality is something that takes time. So it's not as if all these factors will be imminently clear. We also know that some of the providers initially, due to some of the confusion around billing, were sitting on claims. So if you're sitting on claims and you're just submitting them right now, then we don't have a clear picture yet. But if you could go into your system and do a poll from your practice management system and pick a few codes that you think have, a strong evidence base, and that's the kind of stuff that we need to win hearts and minds, are some solid numbers that show cost savings.
Yeah. So Andrew, you talked about access with regard to rural health and some of those maybe, some of the areas that don't have as much money or internet access and those kind of things. We're looking at the triple aim. So it's access, quality, patient and clinician satisfaction, and cost savings. That has been the promise of telehealth. But it also has to reach a fair number of people as well. I mean, does all this have to be bundled together? Is that what you're hearing?
I mean, I think the larger conversation for telehealth right now is, we're acting in a pandemic, right? This is crisis medicine that we've been talking about right now, but telehealth enables so much more for patients and providers beyond just where we are right now, trying to respond to the COVID pandemic. Some of the flexibilities that have been granted by the Centers for Medicare and Medicaid Services, including removing the requirement for patients to be in rural areas. There are a lot of people that struggle, and patients that struggle to make it to a provider that aren't in rural areas. There is a lot that goes into having to go to the doctor, even in urban areas. Things like trying to schedule childcare, time off work, being able to get yourself, whether it's via public transit or your own transportation, to the provider. So part of this conversation, as you talked about, sort of flipping on its head, is realizing that the way that medicine is delivered now is going to be different, because telemedicine enables better outcomes because there is easier access. It's not just necessarily creating more, but it's allowing patients to be able to go to the doctor maybe more often. Patients that normally don't particularly go see the provider if they're sick but can't find time to go now have the ability to take that appointment at the office on a 15-minute break. And so part of what we have to think about when you mentioned bundling everything together is that you have to look at virtual care as not just a response to a crisis or a pandemic, but understanding that the quality and the performance and the payment and really just the overall ability for people to see their provider and be healthier is going to be better moving forward, the easier access they have to get to that provider. So in terms of payment and bundling and all that kind of discussion, it's more than that. It's looking at how virtual care enables a better functioning health system.
Yeah.
Although I was just going to add, I think the bundling part from my perspective, as we look at, telemedicine is a great option. It doesn't fit every scenario. It doesn't fit every patient. We don't really know yet all of the nuances of what's going to be the best specialties, the best kinds of visits. I'm also a little nervous to move too far too fast, because I don't want the payers to come to me and say, you have to do this via telemedicine. I have patient satisfaction data that says it's great, except in 2 of my areas where it's not good. Well, guess what? They're literally between 2 slabs of granite, mountainous granite. The patients don't have access. It was a poor experience. I don't have any way to get them great access, whether we're not, super near on the 5G roadmap and other things. And again, you take 2 slabs of granite, it can be pretty hard to get connectivity in those areas. So those patients aren't going to be coming to do telemedicine happily in the near future. So it is really a balance of, I mean, the bundling piece, both of those, all those pieces have to come together, because again, as we show that it saves money, we will actually transition toward the payer saying, not only now can you do telemedicine, but maybe you must do telemedicine, or we're only reimbursing you at a rate that would be supported by telemedicine because we think that this is capable in this way. Well, the nuances of my geography and that particular patient may not allow for that. And now I'm not able to deliver the quality of care that I want to, or if I do, it's definitely at a loss.
Yeah, and Stephanie, we'll start with you. I'd like to hear from the providers of, if the funding goes away in July, how will your health system think about telehealth? How will they either continue it? How will they pare it back? Where will they continue to apply it? I realize it's a tough question, and it's a speculative.
Yeah, it's actually an easy question for me right now, because our peak is July.
Okay.
That's where we're forecasting, is our peak is going to be later in the summer, or, you know, potentially late, maybe it's moving back to late June, but it's probably July. And so if it's not safe to bring patients in, we're not going to bring them in, and we'll have to find ways to deliver care. So, I mean, I think we'll be forced to continue to do some telemedicine, whether or not we're able to get some of the reimbursement for it. I hope we don't end up in that position, because again, while other areas in the country may have already peaked and are looking at reopening, we are not.
Yeah, that's an interesting point. I'm going to change the question on you, but that's a great point. And I'm going to change the question by saying post-pandemic, right? So I'll just say that because we don't know what the date is.
Yeah.
Post-pandemic, if all of a sudden all the allowances that have been made go away, how will you guys think about telehealth? Or will we snap back to where we were?
Well, I mean, we had a plan for how that was going to be incorporated into specialties. Again, we can still do things like bring a patient to a clinic that's 10 miles from their home instead of 100 miles from their home, and do, you know, a telemedicine visit in a specialty situation. So we'll go back to the construct of the plan that we were ready to roll out based on the limitations we had at the time, and hope that we can continue to evolve the conversation and learn and generate data to help support it.
Albert, how about you guys in San Diego?
Yeah, so I would say we would be pretty much along the lines of Stephanie's comments. I mean, the reality is, you know, whether we like it or not, if we cannot generate a margin, there is no mission, right? That's just a fact of life. And so there have been instances, for instance, where telemedicine has allowed us to do things like do cochlear implants for patients who in the past were not good candidates because they could not drive daily the 2 hours each way to provide their kids the therapy necessary to train that implant, right, to allow them to hear exactly. And we don't see us pulling back on things like that, but certainly for areas where this has become basically a matter of efficiency or satisfaction, if the dollars aren't there, it just doesn't make business sense to continue to provide a service at a loss that we can't afford, right? So we would hope that that those changes are something that have proven in this, as you mentioned, large experiment, that they work. I think our providers and our patients are showing us, now that things are getting back to normal, what are the things that would be sustainable in that way because quality is not compromised and because the service is good, and what were the things that need to get back to an on-site face-to-face type of an encounter, because while telemedicine might have allowed us to get over the hump, it just wasn't optimal. And so, I think there is an opportunity here to trust in our providers who I think have shown across, not just at Rady Children's or in San Diego, but across the country. They've shown their commitment to our communities, to do the right thing, and to kind of let us figure out how things turn out to be, and not remove those regulatory opportunities that have been put in place, so that we can finish through. There's plenty of studies that have been started over the last 8 weeks that are collecting tremendous amounts of data that are going to show not just the immediate satisfaction or effectiveness, but long-term impact of this way of practicing medicine. And I think until we have that data, making changes would be premature. I think we should sustain the changes that have been enabled, and let this, if you will, experiment run its course before we pull anything back.
Fantastic. Praveen, same kind of question for you. I mean, you have San Diego, we have North Dakota, we have DC, and what would the impact be in a major metro like DC, where you're really seeing people, you have the haves and have-nots equally represented in DC. What would happen if telehealth funding would be pulled back?
I think the question is, I think we actually started with that thinking to future of telehealth, and we have a group here. And I think we pretty much believe, I think that the future is optimistic. We know, I think we're thinking, I don't think it's going to go back to the way it is. I think there are a lot of receptivity out there. The question is, how do we shape the changes in the policy as it relates to how we provide care and how do we get paid? I think Maria and we had a lot of conversations. I think that's how we have to focus on. I agree with Al and Stephanie. I think we have to make it a sustainable business model. And we thought about where does the funding come from? There are 3 areas we think the funding is going to come from. The easiest of all that is payment parity. How can we maintain the payment parity? In some confined role, I don't think it is going to stay the way it is. If you couple that with policy and licensure issues and place of service, and you try to put the technology, HIPAA and privacy concerns that has been relaxed a little bit, I think they will regress as they should. But ability to maintain payment parity, and also not only at Medicare level, but also at other provider levels. So that to us is important. And I think if that doesn't happen, I think it'll be very difficult to sustain it. Number 2 is grants. There is a FCC grant out there, which is helping with telehealth, and we applied for that grant. And number 3 is we talk about the strategic bet, and we're talking about strategic bet here. Do we believe that a hybrid model, that telehealth is going to increase the capacity? We know that we have a lot of demand, and we have a lot of wait times. So how do we increase, make it a 24/7 model? So how can we expand the hours? And we are seeing that I think there are ways in which we can have a hybrid model whereby we improve access and make it easy. And I think there's a lot of factors in terms of patients not coming here, they're not spending for parking, they're not taking the day off, and it provides a socioeconomic benefit. And we can partner with the state DC here to fund that. Not only that, but it is a good business model. If we can increase our visit by, say, 15%, 10% or 15% in a new hybrid model, that will pay for itself. How do we do that? For example, I know we did that at my previous employer, Jefferson. We saw that if you look at post-surgical visit, it's part of a global fee. So we pay one fee for the entire global fee. And we were able to get a post-surgical visit online. So and the physicians told us, I said, you know what, initially I used to reserve an hour to meet with the patient after surgery. And now I can do the entire thing in 15 and 20 minutes. So I think that is going to be another way for us to think about how do we expand the capacity. And you have to assume that there is a volume and demand out there. And we believe that there's a demand out there, and we want to think about how can we make it a strategic bet and create a business case to be able to keep it going in the new direction. And the other thing that we're thinking about is the value of the data. And I think, Stephanie, you said that. In my mind, and we have talked to a lot of politicians here, and I'm newbie in terms of talking to politicians. A lot of you might have a lot more experience. But it's about, I think, the winning hearts and minds, and with data, I think it really helps. And we're thinking about what is the value of data, it also in doing a comparative studies, and what is the value from research perspective. And if we can do that, I think we'll be able to shape the future of policy and payment in an effective way. We don't know how it's going to look like, but we want to take an active role given the proximity with both the national and local policymakers.
All right, a couple of rapid fire questions to close this. And then Mari and Andrew, I want you to think about what we would tell or ask of Chime members in order to build the story, right? The data and the story. Think about that. That's what I'm going to end up closing with. But a couple rapid fire questions. If funding goes away for this, will consumers pay for it? Is there an appetite? They've experienced it. They like it. Some like it. Is there a case where you're getting $20 over here, you're getting $20 over here, and we sort of make up the gap? I ask, what do you think is that an opportunity?
I'll go first. We are seeing, we see about 60% of our volume is Medi-Cal, which is the California Medicaid. I don't think they have that luxury. So I think there are some consumers who have that luxury and they will pay for the convenience. I think a big portion of the population we serve, unfortunately, do not have that ability.
And that's a children's hospital. How about Stephanie, Praveen?
Yeah, I mean, I think I would agree. We've got a population of patients who have very limited financial resources, and that's not probably something, I mean, again, and I think that really lends itself more to something like a urgent care, on demand. There can be the occasional, dermatologic or something. I just want to see a dermatologist right now and I can't get into the specialist. But again, I think that further divides maybe the haves and the have-nots when it comes to how we're able to provide care. And I'd like to see us not go in that direction, that if it's something we think is good for patients, we should be doing it for all patients and make it work within the payer construct that we have, and not create different avenues for patients with different financial means.
And I would agree. I think it is all, one size does not fit all. And what we have seen I think consumers are more likely to pay for specialty access sooner than later than for primary care and urgent care. I have seen it. I think the business model is not there, the margins are not there, and the consumer will not, they're not willing to pay for kind of a primary care, urgent care kind of visit. However, we have seen, like, for example, psych, that people are willing to pay. And for dermatology, I think people are willing to pay. And we are finding it out for a subspecialty consult for direct-to-consumer model. I think there's a propensity to pay for a segment of consumer. The question is, how can we create within, and I used to work in retail, and we had a different value proposition for different segment groups. So ethical question that we have, a social question do we have is, can we create a multimodal path here where certain people who can pay will pay, and the other people, and how do we work with our payers to make it affordable for them?
All right, second rapid fire question. How important is it to keep the ability to practice telemedicine across state lines and take those barriers down?
Huge.
Well,
absolutely critical.
Yep,
absolutely critical for us.
Yeah, and all right, so that's a state's. How will this? Will this move us more rapidly away from fee for service and towards population health. And I say that from this perspective. Kaiser does 1 million telehealth visits a year. Well, the reason that we all know the reason they do 1 million telehealth visits a year is because they get paid to keep people healthy and keep them out of the hospital. So they're getting paid either way. Is that the way that this really transitions? Is that we really move those models forward?
Well, I'm an economist by background, so yes, I think life is about incentives, and if you align them correctly, you'll get the outcomes you're aiming for, and if you don't, you won't.
But money talks. That's what I hear you saying, Albert. Anybody disagree with that? I mean, when the alignment's there, it really does work. And I haven't looked at Kaiser's numbers since March 1st, but those are the numbers last year. It was some amazing number of telehealth visits.
What I think I agree with alignment. So to me, but alignment is ever since I came into healthcare, alignment is the most complex thing to achieve. So to me, I think I'm optimistic about it, but I think there are a lot of things that have to be worked out for it to become the main catalyst to move towards away from fee for service.
Yeah, I mean, I think one of the important things to remember about Kaiser is they are the full ecosystem, right? They're paying themselves. Yep. They are the insurance company and they are the provider. It's a much different scenario. You can be part of an ACO or something like that. It's still not the same because it's still two buckets. You're just sharing the risk, and not every health system and every location is going to be in a position to really own the full ecosystem of being both the payer and the provider. And so, I think that is a point of distinction that Kaiser has been able to do a lot of great things and have had that great data actually for several years. But that is a unique way to set it up and is not necessarily reproducible even in an ACO model when the alignment may be there.
Well, let me talk last question for the three of you, and then we'll close with what we can do as Chime members. And that is, is what's going on today, crisis management, is that going to be the same environment? Here's the question. The question is, clinicians today cannot see patients face-to-face in a lot of cases. Therefore, they adopted telehealth. Well, it's one thing to sit in front of your computer and do 20 telehealth visits. That's another to do physical visit, telehealth visit, physical visit, telehealth visit, and whatever. And we implemented this. I implemented it incorrectly a number of years ago, where we were looking at clinicians and saying, yeah, you can do both. And we just know that is a very hard model. Are we going to get pushback from them when there is that when we go back to seeing physically and virtually?
Well, I think your whole point, I think you just made the point yourself there, right? I mean, if you set it up right, that won't happen. We have our places that are most successful are doing block scheduling. So the physician spends the entire morning sitting in their office doing telemedicine visits while their colleagues are using the exam rooms and the nursing staff. And then in the afternoon, they switch. So, I mean, I think it's all about implementation.
Yeah, I would add to that, in a number of specialties, we're seeing severe shortages, right? And I forget if it was Praveen or Stephanie who earlier said some of their specialties were scheduling people weeks and weeks out, right? And what we're seeing is telemedicine is allowing some of our more experienced physicians who are on the brink of retirement to rethink that retirement and say, well, maybe I can continue to work for a few hours a week or what have you in this mode, in a telemedicine mode, continue to do something I love, I'm good at. I just don't want to do this at the pace that I was doing it earlier. And the same thing with young parents, etc. So I think if we do it right, it will not only enable us to continue to provide this service, it would enable us to really generate a force multiplier in our clinical workforce. at least for a while. So I think there is plenty of opportunities. I'm a glass half full kind of a guy, and I think if we do this right, we will see multiple benefits.
Fantastic.
And
Yes, Praveen.
just adding to it, I think it is, to be very frank, I think we heard a lot of feedback from providers across specialties. They said, I'm a convert. I think we need to keep on doing it, but I'm not sure how, because they are sharing the things that are working out really well versus the things that are not working out well. And they are also researchers. So they are actually analyzing their own workflows to think about what is working and what is not working. And we kind of created a slogan. It has to be, we are calling more like a physician and provider driven and professionally enabled. So we have a task group, which basically is called the future of telehealth. And we are 50% of that group is physicians who volunteered to drive this forward. And I believe that I think there is a willingness and a readiness and engagement for us to make it better than it was 3 months ago.
Absolutely. Mari, Andrew, I want to leave you guys with the last word. What can the Chime members do? How can we help to build the story around future funding of telehealth?
Well, we are actually going to be launching a survey, which I am not always I'm always hesitant to clog our members' inboxes more, but in this case, I think we need some data and we need some stories. So we'll probably be doing that in the next, 2 weeks. So keep your eyes open for that. Contact us. We're also happy if you're busy, you can ask your staff who have a lot of expertise in telehealth to contact us. So we want to start collecting that evidence base. So be on the lookout for that. And I don't know if Andrew wants to add anything else to that.
Yeah, and I think when you talk about stories, Stephanie has talked about some of the challenges when it comes to virtual care, and Albert and Praveen have talked about how it's experienced in their areas. This is an opportunity of time for innovation when it comes to virtual care. So we need to hear the good and the bad, the great solutions that you've come up with and the things that you've tried that didn't work. It's really important for us to be able to understand the policy and how the policies need to be enacted, because everything doesn't fit everyone, as Stephanie was mentioning. And so it's really important to understanding what works for who and what doesn't work for those others.
Fantastic. You guys did not disappoint. You're a fantastic panel. I love the back and forth. I tried to stump you a couple times, and I appreciate all the answers. That's all for this week. Thanks to our channel sponsors, VMware, Galen Healthcare, Starbridge Advisors, ProTalent Advisors, and Sirius Healthcare for choosing to invest in the next generation of health leaders. If you want to support the show, best way to do that is to recommend it to the peer. Sorry, my phone's going off here. Must be time for my next meeting. And the next best way to do that is to subscribe to the YouTube channel. Thanks for listening. That's all for now.